Our first speaker today is Dr. Monique Giraud, who is Assistant Professor in the Division of Clinical and Epidemiological Research in the Department of Obstetrics and Gynecology at Duke University Medical Center in Durham, North Carolina. She is also a staff gynecologist at the Durham Veterans Administration Medical Center and is a graduate of Harvard University and Brown Medical School. Her research interests are focused on the management of high-risk pregnancies and include the molecular biology of adverse pregnancy outcomes, epidemiology of adverse pregnancy outcomes, racial disparities in women's health, and health service research, outcomes and quality in women's health. Dr. Giraud and colleagues recently co-authored research on preeclampsia and stroke risks during and after pregnancy, and has proposed a multidisciplinary, community-based internatal care model focusing on postpartum and preconception prevention and treatment to improve maternal-child health and interrupt the cycle of events leading to maternal and infant complications in pregnancy. She will discuss contemporary management of high-risk pregnancies, focusing on maternal, fetal and neonatal risks. Please join me in giving a very warm welcome to Dr. Monique Giraud.
Good morning. It's a real pleasure to be here and to be speaking to a group of colleagues. Very exciting to be coming from the United States to Ireland, a country I've been wanting to visit for some years. And so especially thank you, Doctor, regarding the warm welcome that you've given me and my colleagues as we've come. And so this morning I would like to discuss the contemporary management of high-risk pregnancy. I need to start off by saying that I am not a maternal-fetal medicine specialist. I am a generalist, and so therefore I have to keep things simple. I'm not as sophisticated a researcher as Dr. Ellard Koch here from Chile or Dr. Calhoun, who's a maternal-fetal medicine specialist, so I have to keep things simple for myself. Nevertheless, like most of you, I suspect I do end up managing pregnancies that are high risk, specifically preeclamptic and other types of pregnancies, and that's the purpose of my talk this morning. Okay, so to start off, we always have to have our disclaimers. I don't receive any royalties, speaking fees, or honoraria from drug companies, nor do I perform research for pharma. And so how do we define high-risk pregnancies? High-risk pregnancies are pregnancies where one or more medical or obstetrical complications occur requiring medical or surgical intervention, and where the care of the mother and fetus overlap. And I think that this is true in all pregnancies. Of course, the care of the mother and the fetus overlap. They're integral. But at the same time, in high-risk pregnancy, people have often said that there's conflict or competition between the needs of the woman and the needs of the child. I don't really think that that's true. I think that really what it comes down to is understanding the particular circumstances of that pregnancy and dealing with it in a scientific and rational way. Now, if I can get this to work. Okay, here we go. So why do we care about high-risk pregnancy? Poor outcomes in high-risk pregnancies are major contributors to maternal, fetal, and neonatal mortality and morbidity. These are associated with the prevalence and severity of high-risk pregnancy in the population. And in fact, as countries undergo a demographic transition from causes of maternal mortality related to obstetrical care, you see a shift in the types of pregnancies that are defined as being high risk. And addressing the predictable causes of high-risk pregnancy, because there are some causes that are not predictable. It can be very difficult to predict which woman is going to have a postpartum hemorrhage, for example. But to the extent that we are able to predict and intervene, we can help reduce maternal, fetal, and neonatal mortality and morbidity. Now, the likelihood of a pregnancy being or becoming high risk is affected by many factors. There are first trimester factors, first and second trimester factors, that are anatomical, second and third trimester factors such as chorioamnionitis, and then of course our nemesis, our obstetrical nemesis, which is preeclampsia. Now in Ireland, I do need to commend the obstetricians of Ireland because Ireland has consistently one of the lowest maternal mortality rates in the world. So I really think that the obstetricians and midwives of Ireland and GPs need to be commended for this. Over the course of 10 years, this is data that I had received, there were a total of only 23 maternal deaths, which is quite remarkable. That's significantly lower than our rate in the United States. You'll see that ectopic pregnancy, there were some deaths from ectopic pregnancy. Preeclampsia was another cause of maternal death. Cerebrovascular disorders in the puerperium is probably referring to postpartum eclampsia complicated by stroke, and then other unspecified pre-existing hypertension. And so you can see sort of a diverse group of obstetrical disorders. But the fact that only 23 women died over a 10-year period is really quite amazing. Now, just very briefly, risk screening during the antepartum period, the goal of prenatal care is the birth of a healthy baby with minimal risk to the mother. And I would add to that having a mother who is in good condition as well. And of course, the cornerstones of prenatal care for us as obstetrical practitioners is accurate assessment of gestational age, identification of the potentially high-risk patient, for example, the woman who has an underlying thrombophilia or who has chronic hypertension, ongoing evaluation of the mother and the baby, anticipation of potential problems before they occur, and communication with and education of patients. Despite our reliance on prenatal care, it's surprising that in large trials, large randomized controlled trials, prenatal care has not been shown to actually lead to improved outcomes. I think part of the reason for that is that, as we saw earlier in the slide on mortality, some of the causes of perinatal death, perinatal maternal death, are simply not predictable. And of course, the most notorious is postpartum hemorrhage. However, it remains a little discouraging that despite our faith in prenatal care, we can't demonstrate scientifically that it makes a difference. But in our hearts, we believe that it makes a difference. Now, preeclampsia is a subject of great fascination. I would have to call this our medical or obstetrical nemesis. It's a hypertensive disorder of pregnancy, which is in fact increasing in prevalence worldwide, in particular in developed countries. Eclampsia is derived from the Greek word for lightning. It was actually described by Hippocrates because he noted that the seizures were occurring in women and that these seizures were somehow different from epilepsy. And so he called this eclampsia. It's been called the disease of theories because despite about 130 years of research, we still don't know what causes preeclampsia. There's no effective diagnosis or treatment. Now, there's a classification of the hypertensive disorders complicating pregnancy, and I'm sure most of us are aware of this. I'm going to review this very quickly. Chronic hypertension is hypertension that antedates the pregnancy. There's preeclampsia, which may or may not develop into eclampsia. There's preeclampsia, which is superimposed upon chronic hypertension. And then there's gestational hypertension, which is a mild transient increase in blood pressure, which returns to normal postpartum and is not associated with significant increases in morbidity and mortality. Now, preeclampsia is a disorder that's unique to human gestation. There are no naturally occurring animal models for preeclampsia, which has been a significant obstacle to trying to explore it from a research perspective. Genetic knockout mice, specific genes can be knocked out, which will cause a preeclampsia phenotype. But the fact of the matter is we simply don't have an easily understood model. And all of the animal models that are available are rodent models. There are no primate models for study. We are aware that preeclampsia presents as de novo hypertension excuse me, and proteinuria after mid-pregnancy. Again, the cases that are superimposed on chronic hypertension or renal disease tend to be the most severe cases, tend to occur earlier in gestation and necessitate delivery. It is a systemic disease. It is not simply a disease of the pregnancy. It appears that some of the contemporary thinking about preeclampsia is that there's really underlying metabolic or vascular disease in the woman that's reflected in pregnancy. In other words, the relative dyslipidemia of pregnancy, the relative increased inflammatory state of pregnancy provokes a stress test of the woman, which results in her becoming preeclamptic. This is one of the current theories about it. And it's also the leading cause, probably one of the leading causes of preterm birth. Now, interestingly enough, as we all know, I'm sure many of you have been caught out this way, preeclampsia does not always resolve with delivery. So even though we know that the placenta is necessary for the development of preeclampsia, delivering the placenta does not always cause the disease to go away. Many of us have had the experience of having a lady come in a week after delivering extremely hypertensive with severe proteinuria or eclamptic when the placenta has long gone to pathology and done whatever it needed to have done to it. So this shows us that there's really a lot that we don't know about preeclampsia. Now, preeclampsia is clearly increased in women with hypertension, diabetes mellitus, renal disease, and other underlying comorbidities. It is very difficult to diagnose, and in fact, one of the most difficult diagnoses toward term is in the woman who has severe chronic renal disease. It can be extremely difficult to tell whether they're having an exacerbation of their renal disease or true preeclampsia. The difference is important because could I get some water, maybe? The difference is important because if it is truly an exacerbation of preeclampsia, she needs to be delivered, whereas if it's renal disease, she could potentially be treated with steroids and other drugs in order to try to control her blood pressure. Interestingly, preeclampsia is less common in Paris women unless they've had underlying risk factors such as hypertension or renal disease. One of the most fascinating things about preeclampsia, and the subject of my own research, is the fact that it predicts later cardiovascular disease. The relative risk for a woman having preeclampsia, about 50% of them will develop chronic hypertension within 5 to 10 years after giving birth, similar to gestational diabetes. Women with gestational diabetes, approximately 50% of them will become frank type 2 diabetics within 5 to 10 years of delivery. The same thing appears to occur with preeclampsia, and thank you very much. Much better. The same thing appears to happen with preeclampsia, and in fact, the earlier a woman develops preeclampsia, especially if it's before or around 28 weeks, or the more severe it is, the more likely she is, with a relative risk up to 8, to develop cardiovascular disease after giving birth. And in fact, there's research from the United Kingdom which shows that women who have severe preeclampsia and go on to develop vascular disease often have a stroke or MI in their late 40s. And in the study that we did in the United States at Duke University, the mean age at which these women had their MI was 39 years. And when they had their first MI, it was their last MI. They usually died at the time or shortly thereafter. So this is going to be very significant, I think, as we begin to look at cardiovascular disease and preeclampsia as a risk factor for cardiovascular disease. Now, if we look at causes of hypertension in pregnancy, you can see that the majority of them, a majority of what we would call hypertension is gestational hypertension, which really cannot be said to be hypertension that has long-lasting effects. Preeclampsia, essential hypertension, is probably the second largest category. Again, this is all very population dependent, and in populations such as African Americans, Caribbean Americans, that have higher baseline risks for chronic hypertension, risks of preeclampsia are higher as well. This slide never comes out quite the way I want to, but the main take-home message from this is that preeclampsia, again, it's going to remain a disease of theories. One of the problems with preeclampsia is its complexity. And the complexity is due to what we call in epidemiology heterogeneity. In other words, preeclampsia is probably not a distinct disease. Thank you. That's great. Preeclampsia is probably not a distinct disease. When you have diseases like this that have multiple risk factors, paternal susceptibility, if your husband's mother had preeclampsia, you, as his wife, are more likely to develop preeclampsia. There's a clear genetic predisposition to preeclampsia. Sisters have a higher risk if their mother had it. There's a question of whether there's susceptibility as couples. There's maternal susceptibility. All this is telling us is that preeclampsia is probably the final common pathway of a series of unrelated diseases that the maternal vasculature simply responds in a certain way. Not that it's a distinct disease with a variety of different causes. And the reason that's important is that it makes it very difficult to predict and difficult to treat. So what do we do as clinicians? Let's look quickly at cardiovascular adaptation in normal pregnancy. Early on, due to the effect of particularly progesterone and estrogen, there's systemic vasodilation with increased cardiac output. There are modest decrements in blood pressure. In fact, this is one way that you can often identify women who have chronic hypertension. Their booking blood pressure is usually in the 78 to 80 range. It shouldn't be. Usually by about 8 weeks into pregnancy, there's been vascular remodeling in pregnancy so that those women tend to have lower blood pressures than they would have had pre-pregnancy. There's arterial compliance. Arteries and arterioles become less stiff early on in pregnancy. And so what happens is that as time goes along, blood pressures do tend to rise toward term. And in fact, if you look at blood pressures in a group of European American women with normal pregnancies, if you're a para 0, you have a nadir in your blood pressure here earlier on in pregnancy, and then it starts to slowly rise into the third trimester. And the same with diastolic blood pressure. Now, criteria for the diagnosis of preeclampsia, we all know 140/90 is the unfortunate number. I can't say it's the magic number. And proteinuria. And then these are the following criteria that upstage preeclampsia from mild to severe. Visual disturbance, any sign of central nervous system dysfunction, symptoms of liver capsule distension. I was talking about this with Dr. Calhoun. All a woman has to say to me is, my right side hurts, and that's it. As he said, I'm no longer committed to maintaining this pregnancy. You need to be delivered. Hepatocellular injury, which is manifested by serum transaminase, severe blood pressure elevation. And one of the issues with our blood pressure definition is that it's probably too high. It's a very interesting study, and I don't know really why this study didn't get more attention than it did. It was from Mississippi, and in Mississippi, in the American South, we have very high rates of hypertension, very high rates of preeclampsia. In this particular group of patients, they had a large number of them that experienced stroke at blood pressures that we would really not consider that abnormal. I remember in training when I was told, well, you know, if the diastolic blood pressure is not greater than 105, you don't really need to treat. If you look at this data, you see that these ladies had their stroke anywhere from about a diastolic blood pressure of 81 to 113. Now, the 113 is that's getting up there pretty high. But again, their pre-stroke blood pressure, systolic blood pressure was 175. Moreover, if you look at their outcomes, and these are some of their symptoms, these are things that you might expect, you know, headache, nausea, vomiting, epigastric pain, and so on. But if you look at their outcomes, they were dismal. And if I can get this to work, okay. 15 out of the 28 died. 15 out of the 28 were comatose. There was eclampsia in 8 out of 28. And this is also very interesting to me. A number of them died from hypertensive complications without becoming eclamptic. So what I think this is telling us is that we really are probably not using stringent enough blood pressure criteria before we decide to treat. These are, again, getting back to the theories of preeclampsia, and I want to draw your attention. There's been a lot of discussion about vascular endothelial growth factor receptor and soluble endoglin, the whole angiogenesis, anti-angiogenesis, and I want to get into this because it gets to be pretty molecular after a while. The whole angiogenesis, anti-angiogenesis set of theories. Again, the problem is that despite very large amounts of money and large trials by pharmaceutical companies, none of these biomarkers, have been shown to be predictive for preeclampsia. I'm going to skip through this here. And in fact, the systematic review, there's been a more recent one, but this one was really an excellent systematic review. It was 7,191 articles, 211,000 women, and their conclusion was that there is still no clinically useful screening test for preeclampsia prediction. And the measures of these angiogenic and antiogenic cytokines are inconsistent in their sensitivity and specificity. So what all that is saying is that we really don't truly understand the biology of this disease. So again, what's a clinician to do? We can think about looking at some of the prevention and intervention trials. I think initially, maybe about 10 years ago, we were excited about aspirin, but again, the meta-analyses have been very conflicting. And again, I think that's because, as I said earlier, preeclampsia is probably a final common pathway with many entry points. A woman with chronic hypertension has one sort of entry point. A woman with collagen vascular disease has another type of entry point. And then the perfectly healthy woman with no pre-existing comorbidities, some of the ones who become the sickest, we don't understand what their entry point is. So therefore, we're not able to classify the disease accurately. So of course, our prevention trials aren't going to make sense because we're treating all different types of patients. Now, even though use of antihypertensives does not decrease preeclampsia incidence, we still need to treat. There were studies of fish oil, vitamin C and E, and interestingly, vitamin D is being investigated in clinical trials. Again, there is conflicting evidence that you can look at quartiles of vitamin D levels and see significant differences in rates of preeclampsia. But again, this is probably, there's probably some genetic variation and pharmacogenetic variation. So this is just a quick algorithm. If a patient is at 40 weeks gestation, it's easy. with a Bishop score greater than 6. If she's non-compliant, then it's reasonable to get her delivered. If not, we can attempt to temporize until there's been a deterioration in maternal or fetal condition, at which point we would move to prostaglandin ripening of the cervix and oxytocin induction. Now, serial laboratory data, as we're all aware, are very helpful in recognition of superimposed preeclampsia. That's the type of preeclampsia that we're most concerned about, because approximately a quarter of women who have chronic hypertension will present with superimposed preeclampsia in the 3rd trimester. But we should mention conservative management. Why? Because the vexing problem is the woman who comes in at 27, 28, 29 weeks, starting to look preeclamptic, where you're beginning to be concerned about fetal status. The baby looks good, the baby's a little small, but what exactly do you do? The fact of the matter is that there are studies, especially Dr. Sabai, who used to be at Tennessee, found that prolonging pregnancy does lead to minimal fetal outcome, but the maternal morbidity increases dramatically. Why? Because what is a singular characteristic of preeclampsia is its unpredictability. And the woman who looked good 4 hours before develops fulminant illness. I see Dr. Calhoun nodding sagely over there. And so the thought is that you can temporize as long as the blood pressure control is acceptable. And at different institutions I've been at, people will say, well, put her on her left side. All you've changed is her hemodynamics. You haven't changed the underlying disease. And so even if her blood pressure is 150/90 on her side, the disease process is still going on. And so I'll tell my residents, no, put her flat on her back and let's see what her blood pressure really is. Let's not fool ourselves. So I'm sure I don't know if everyone has seen this, but can someone tell me what that is? That's the liver. This is a liver capsule rupture, which is one of the most feared consequences, obviously, of the HELP syndrome, hemolysis, elevated liver enzymes, and low platelet count. So eclampsia, again, prevention, magnesium is the drug of choice. In the MAGPIE trial, a very large study, 24 hours of magnesium prevented seizures. As I said earlier, it can occur days to weeks postpartum as well. And these are some drugs for chronic hypertension. This will be available, so please don't stress out about not having this. Of these drugs for treatment of urgent hypertension, labetalol is probably the most effective. It gives both alpha and beta adrenergic blockade, giving them 20 milligrams IV. But again, you can only give a patient so much labetalol. At some point, you have to make a decision. We're just going to deliver her. And I'm going to skip through this. And of course, we want to watch out for the other maternal outcomes, antepartum hemorrhage, abruption, postpartum hemorrhage. And so to summarize, one of the key issues is to reconcile the question. Again, if the patient is at 40 weeks, it's straightforward. You get her delivered. But in the preterm arena, we do want to begin to consider maternal fetal status. And I remember years ago having a case of a fetus that was about 25 weeks, and we really agonized over what to do, and finally decided we needed to do hysterotomy. We needed to deliver at that gestational age because that was the best thing for the mother. At the same time, we do have the ability to try to temporize for a short period of time in order to give the opportunity for betamethasone or dexamethasone, I don't know which steroid is more popular here, in order to give the baby a chance to develop adequate lung maturity. Okay, so when you look at this, I'm really having trouble with this here. Okay, and you can look at this on the thing. I did mention earlier about deaths from cardiovascular causes, non-preeclamptic. Preeclamptic preterm delivery is the highest risk, again, a relative risk of 8, whereas down non-preeclamptic preterm delivery, even in preterm gestations without preeclampsia, there is a higher risk for future cardiovascular disease. So again, when you see a woman for the first time in your office for an annual pap smear, you may ask, have you had a history of adverse pregnancy outcome? And if she has, it might be prudent to begin to do some other inquiry into her cardiovascular status. And again, the purpose of treating preeclampsia is to prevent the adverse outcomes, to deliver a surviving child at an appropriate gestational age as much as possible, and to prevent mortality and residual pathology in the mother by optimizing the condition of the mother. I'm going to talk briefly about ectopic pregnancy. Again, this is a research interest of mine. And why? Because this is the leading cause of first trimester maternal death, and one of the leading cause of all-cause mortality in pregnancy. As much as 6% of early maternal mortality is due to ectopic pregnancy. The maternal case fatality rate has declined in the United States, and I'm sure here in Ireland as well. Why? Because of HCG, serial HCG, quantitative HCG, and transvaginal ultrasound. Even with the use of these diagnostic tools, 40% of women are misdiagnosed on their first visit to the emergency department. The differential diagnosis is not that extensive, but it's a combination of history, physical, and laboratory evaluation that gives the highest likelihood of correct diagnosis. When I was a resident hundreds of years ago, we were told that the triad was amenorrhea, pelvic pain, and bleeding. But it's a similar story for miscarriage as well. And so, just to review, ectopic pregnancy occurs when a fertilized ovum implants within the fallopian tube. 93 to 97% of them implant in that site. However, increasingly in the United States, and possibly in Ireland as well, the cesarean scar ectopic pregnancy is becoming a significant problem. We're also seeing more cervical pregnancies as well. Why is that? Because our rates of cesarean section within the United States are over 40%, result in a scar which an ectopic pregnancy is able to implant within. And these are very difficult to manage. And the incidence is increasing in all nations of the world where the cesarean rate is increasing. Heteroectopic pregnancies are also increasing, 0.3 to 0.8% of the general population. This is where you have coexisting intrauterine and ectopic pregnancies, and in 1 to 3% of in vitro fertilization pregnancies. So again, this is showing the possible sites of implantation. It can be in the fallopian tube, the isthmic portion of the tube, the intramural portion, cervix, ovary, and then abdominal. Now, this is a picture, if everyone can see this. Just to orient you, cervix is here, the fundus is here. This is decidua within the endometrial canal. Now, you might think that this is an intrauterine pregnancy, but you'd be wrong because this is the endometrial canal here, and this is outside, okay? This is a cesarean section ectopic pregnancy. This is another one. Again, here is the uterus here, and the ectopic pregnancy is clearly outside of the serosa. And this is a real nightmare. This is an intrauterine pregnancy with an ectopic pregnancy and a cesarean section scar, which is really a very difficult situation. And finally, this is a cervical pregnancy. Again, here's the uterus here, endometrium here, the cervix is here. So the risk factors for ectopic pregnancy: prior pelvic inflammatory disease, prior abdominal surgery, Crohn's disease, use of an intrauterine device, and infertility. IUDs themselves do not confer an increased risk for ectopic pregnancy, but if a woman becomes pregnant with an IUD in situ, her risk for ectopic pregnancy is markedly higher. And here's another list: tubal ligation, tubal pathology, previous cervicitis, smoking, and so on. Now, the pathophysiology of ectopic pregnancy is that the embryo grows and develops, but the fallopian tube's vascular supply can't support trophoblast growth. The trophoblast is burrowed into the wall of the fallopian tube, but it's simply not able to support the embryo. So there's dysfunction of the trophoblast, HCG levels decline or plateau, and at the same time, because the corpus luteum is not getting normal hormonal signaling from the trophoblast, there are low progesterone levels. This is why it's much more appropriate to think of ectopic pregnancy as a special case, almost a special case of miscarriage. These pregnancies are not viable. There's no way to make them viable. And even though people have asked, well, can't you take the baby and reimplant it? But it's not possible. So lack of adequate blood supply and hormonal support to the developing embryo may result in cessation of growth, death, and spontaneous resolution. And this is where, as clinicians, we get fooled. The decidualized endometrium may slough as a cast, and the patient says, well, I passed this thing, it was kind of fleshy and rubbery. Okay, she's passed tissue, you look, the cervix is closed, case closed. But it leads the clinician to diagnose falsely a completed miscarriage. Trophoblastic tissue can also persist, growing and invading. As it invades into the mucosa, it causes tubal distension and bleeding. It causes the tube or uterine wall to rupture, causing intra-abdominal hemorrhage, and this is our most feared complication. So again, traditionally any woman with the triad of bleeding, amenorrhea, and abdominal pain was felt to be at high risk for ectopic pregnancy. But the fact that mortality persists, and also the fact that the frequency of diagnosis is so high, suggests that we need better diagnosis. And we have the tools to do that. The combination of transvaginal ultrasound and serial HCG, quantitative HCG, in a woman with a positive pregnancy test appears to be the most sensitive and specific combination of tests. We're about to publish an article on, it's a meta-analysis of ectopic pregnancy that examine these very issues. Serum progesterone levels may be helpful in assessing pregnancy viability, but they don't have a role in the diagnosis of ectopic pregnancy. Here is, and again, I'm going to run through this very quickly. If you have a patient who has a positive HCG and she's hemodynamically stable, you can continue to try to evaluate. And depending on the skills of your sonographer, what's the threshold for detection of an intrauterine pregnancy or an adnexal pregnancy given a specific range of HCG. Of course, if she is hemodynamically unstable, then immediate surgical consultation is needed. And then these are the significance of the features associated with ectopic pregnancy. Vaginal bleeding, abdominal pain. This is sensitivity and specificity of each of these particular characteristics. As you can see, many of them perform poorly. Some of them perform very well, peritoneal signs. But of course, by that point, there's really very little doubt as to what you should do. The patient needs to go to the OR. An adnexal mass, of course, has high specificity. And fetal cardiac activity, again, as my kids would say, duh. Okay, presence of color flow Doppler and so on. So again, as clinicians, what do we do? Stable patients where the diagnosis is equivocal may be candidates for expectant management. Close follow-up and communication are necessary. And then the science clearly shows that serial HCGs over a period of 48 hours will be helpfully diagnostic in a helpful sense. Now, in patients with a low HCG and no visible intrauterine or tubal pregnancy, the false positive rate is high. In the United States, there's been a move towards curettage of these pregnancies, but in this situation, there's a significant possibility of terminating a viable and desired pregnancy. If a patient is at high risk for loss to follow-up, they're homeless, substance using, mentally ill, or socially at risk, it's not unreasonable to admit them, because there's a possibility that they might be brought into the ER dead in a few days if you don't do that. Another issue is the use of methotrexate. Methotrexate has been widely used in the United States, but there are many caveats to its use. With surgery, there are some data indicating that there's a lower risk for persistent ectopic with surgery, because with methotrexate, the criteria for using are actually fairly stringent. There can't be fetal cardiac activity. The ectopic has to be less than 2 centimeters, preferably less than 1.5 centimeters. And one of the major mistakes that occurs with use of methotrexate is to not document the location of pregnancy. I know of a patient that received methotrexate and pregnancy was never documented as being an ectopic pregnancy. And as it turns out, she had no tubal pathology. So she was given methotrexate probably, which ended up in the demise of a normal pregnancy and 2 desired normal pregnancies. And so for cervical and cesarean scar pregnancies, it's a bit of a different story. Your surgical options are very limited. Attempts to address cervical pregnancy surgically can be pretty catastrophic, resulting in hysterectomy. And so at the present time, there's still controversy as to which is the best means of addressing it, except in these 2 particular cases where, again, with cesarean scar pregnancy, if it ruptures into the bladder, that's a catastrophe as well. Okay, we'll talk briefly about chorioamnionitis. I think I'm not doing too badly for time. This is referring to amniotic fluid, membranes, and placenta. Frequency is inversely related to gestational age. It's more common in premature pregnancies, and it may be the cause or effect of preterm delivery. This is highly associated with poor neonatal outcome, including sepsis, pneumonia, and cerebral palsy. The risk factors for chorioamnionitis are nulliparity, longer length of labor, length of time membranes are ruptured. Initially, for many years, the thought was that it was due to the number of examinations, but as it turns out, that's confounded by the length of labor. So it's really probably the length of labor rather than the number of digital examinations that's associated with increased risk in those longer labors. Internal monitoring, of course, group B strep, And interestingly enough, multiparous patients are at much lower risk for chorioamnionitis than primiparous. These are the organisms that are isolated in the amniotic fluid of patients with intraamniotic infection. As you can see, the most common isolates are Mycoplasma hominis and Ureaplasma urolyticum. It's hotly debated in the research community as to whether these are true pathogens or just opportunists, but the fact that recent data suggests that they can truly be pathogenic as opposed to E. coli and group B strep, which there's clear data. Gardnerella vaginalis or bacterial vaginosis is probably not a pathogen, but really simply a marker for susceptibility to preterm birth and preterm premature rupture of membranes. That's why very large-scale trials of treatment of bacterial vaginosis had negative results or actually worse results. It's probably reflecting a majority of women who have persistent BV, especially African American women, actually have vitamin D deficiency. And so this is really reflecting colonization by an opportunistic host rather than pathogenic invasion. And so treating their vitamin D deficiency in many cases will make the BV go away. Now, of course, physical examination, laboratory studies, maternal fever with or without uterine tenderness, leukocytosis are all suspicious. The research definitions are a bit more stringent, simply because research definitions tend to have to be. And amniocentesis for amniotic fluid culture is the best method for diagnosing intraamniotic infection in preterm gestations. Although by the time you get the data back, it's 3 days later, you've already made a decision one way or the other. But Gram stain is preferable. Gram stain of amniotic fluid is especially helpful in a very preterm patient who has symptoms suggestive of chorioamnionitis, but for whom intervention would have difficult consequences. For example, on another occasion, I was aware of a patient who was approximately 27 weeks gestation and who had a breech fetus, who came in with fever, abdominal pain, and uterine tenderness. And the resident said, we have to do a C-section. I said, okay, but you're committing her to having classical C-section and having to have a C-section next time when we don't know for a fact what's going on. So her amniotic fluid was perfectly clean, and as it turned out, she had C. diff colitis. And so in that case, just doing the amniocentesis really saved this lady from having profound morbidity to her baby and the future morbidity of having repeat cesarean sections by being able to go through the differential diagnosis. Okay, and then this is just amniotic fluid, glucose concentration, abnormal results are less than 15, WBC greater than 30, and leukocyte esterase activity. Okay, and one of the reasons we get concerned about intrauterine infection isn't just childbirth fever, it's the very serious effects on the fetus. The perinatal inflammatory response to chorioamnionitis is very profound, and it's increasingly research associates the presence of infection, not necessarily fetal infection, but infection in membranes and in the umbilical cord with adverse long-term effects, specifically cerebral palsy, in fetuses. There's vasculitis and punicitis, inflammation of the umbilical cord, elevated cytokines, and a neuroinflammatory response, as well as endothelial activation. And even though the brain is not infected, you see activation of astrocytes and microglia. So what this is saying is that even though we are concerned about the development of fever and sepsis, adult respiratory distress syndrome in the mother, the fetal complications are very profound, especially such complications as cerebral palsy. In these patients, bacteremia is fairly common, 5 to 10%. Cesarean delivery increases the risk of surgical complications, and obviously outcomes are better with early antibiotics rather than postpartum. Okay, so just to wrap up, if I can. Okay, and this is what I was getting at earlier. So again, in the neonatal period, you can see on ultrasound or MRI white matter damage, gray matter reduction, cerebral palsy, mental cognitive limitations, and learning difficulties. So this is something that we want to be aware of, and at whatever gestational age, intervene, both for the sake of the baby and for the sake of the mom. Here's some outcomes in intraamniotic infection in term. You can see sepsis, rates of sepsis are fairly high. Pneumonia is high as well. IVH is much more common in the preterm fetus, but that's confounded simply by the fact that they're preterm as well. So As obstetrician gynecologists, we have a wonderful privilege. Even though our specialty, to some extent, may feel occasionally as though we're under attack from the standpoint, at least in the United States, the standpoint of litigation and so on, but there's something so amazing about being in this specialty. We have a unique and special privilege. It's to help and support the women and the children who are our patients, because even though we have our neonatal colleagues in to help us, ultimately during the pregnancy, we are taking care of these two patients. And we're there with them through these sometimes very difficult and very challenging situations. So therefore, it's our responsibility at all times, and I almost don't need to say this because Ireland's maternal mortality is so low, to act with the intention of primum nocere nocere, first do no harm, even in these very difficult and sometimes puzzling situations involving chorioamnionitis, ectopic pregnancy, preeclampsia, because we're all doing the best thing for the patient. So thank you very much for your time.